Okay, so now we're going to go over a lot of the superficial palpations that you guys are going to need to know. And the first that we're going to start with are the anterior. When we talk about the patella, it is the biggest sesamoid of your bone, meaning that it's a floating bone. It doesn't actually have true articulations with any of the other bones, and it's completely encapsulated by your suprapatellar and infrapatellar tendon, which is what helps put or insert your quad tendons on the tibial tuberosity. So what we look at is this flat part that's on the top. It seems counterintuitive, but it's called the base, and then the pointy part at the bottom is the apex. Your quads come down, and we've talked about them in previous chapters, but you should know all four of them come together to form that suprapatellar tendon. They fully run around your patella and then become your infrapatellar tendon and insert on this bump right here, which is called your tibial tuberosity or your tibial tubercle. Some of you may have really big bumps here, and they probably grew when you were in adolescence or in young age, when you were going through really big growth spurts. And this is something that happens commonly, and it's an apophysitis injury where part of the tibial tuberosity, because your bones are growing so fast, it fractures off and then grows back on and fractures off and grows back on. So over time, what happens is it gets really sensitive. You get a big knot there. Some people almost looks like a horn kind of growing out, and it's really tender to touch. So kneeling on it and that kind of thing can be really tender. Everybody, for instance, Robbie, there is no huge knot right here, but it definitely is here. And if you follow the infrapatellar tendon down, you can definitely palpate straight onto it. So then after that, you would come up a little bit and you would see your tibial plateau. And on some people, like on Robbie, you can kind of see it stick out a little bit. And as you run over the top of it, you would go into the joint space. And you should be able to see how my fingers are kind of going in there. So this last little ridge that's right here, this is our tibial plateau right here. And then inside of that is our joint space, and then we would have our medial meniscus and our lateral meniscus that ride on either one of the sides of your infrapatellar tendon within this joint space. Are you truly palpating the meniscus? Not really. I mean, maybe a little bit if they're in a really flexed position and you're really kind of pushing in there, but when they're in a relaxed position like this, not quite as much. It's more difficult to be able to do those palpations. From there, we can also feel, so we're going to have our infrapatellar fat pad, and that's going to sit just posterior to this, and if it's inflamed, you can sometimes feel it squishing out on the sides, and they're going to complain of pain, and especially if people have swelling or injury inside their knee, so meniscal, ACL, or PCL, this joint line is actually going to be swollen, and it might even kind of puff out as they go into this flexed position. Then as we continue a little bit higher, you're going to feel these kind of rounded areas. This is the anterior aspect of your femoral condyle, and you have a medial and a lateral. And then if you've moved laterally, you should be able to feel how it's rounded down that middle or the medial side, and then the same on the lateral side. The femoral condyles should be superior to that tibial plateau that we talked about. And as we talk about the MCL and the LCL, they are going to insert onto the medial, so the MCL inserts on the medial condyle and then just distal to the medial tibial tubercle or plateau, and then the LCL is actually going to come off of your lateral condyle and then insert onto your fibular head. So being able to palpate your fibular head is also going to be important on the lateral side. And the way that you can usually do that is if you're going to dissect the tibia in half, front to back, and then you come into the joint line and run down, you should feel a nodule that kind of sticks out, and you should be able to run over the top of it. And there are joint moves that you can do of this, and we'll talk about those in the lower leg, but you should be able to palpate that fibular head. And one of the things that we talk about for identification of structures, if I can see the patella, I'm definitely on the anterior side. If I can see the fibula in its entirety, I'm going to be on the lateral side. So there's always things that you should be looking at to be able to figure out where you are. Then we've talked before about the pes anserine and Gerdy's tubercle. The pes anserine is going to be medial to our tibial tubercle or tuberosity. And remember, that is where our sartorius, our gracilis, and our semitendinosus are all going to insert. And the way that you would verify that, and one of the easiest ways I think, is to find the semitendinosus tendon. So asking the patient to kind of flex or bend their knee, other way, go backwards against my hand, there you go. And then you would follow that tendon all the way around until it ends right there. You could do the gracilis, but it's a lot harder to find the gracilis tendon, and the sartorius down this far is a little bit harder to find as well. But I think using the semitendinosus is a great way to identify where that pes anserine is. For Gertie's tubercle, we've talked about palpating the IT band as it runs down, and you should feel that really fibrous structure on the lateral side of their leg. And as you move them, remember, you can kind of feel it snapping over that lateral femoral condyle as they move around 30 degrees of knee flexion. So we're kind of going like this, and you can feel that structure. And if you follow it all the way down, you will feel that it ends, again, almost on the same line as the pes anserine, but on the lateral aspect of the proximal tibia or the tibial tuberosity. And that is Gertie's tubercle. Also another location that you need to be able to find and be able to palpate in the, that is associated with the knee and on the tibia itself. When we talk about the ligaments, the MCL, again, I already talked about where it is. Remember, the way that we know that we're palpating on them is to stress them. So to stress the MCL, you would apply valgus stress. So they need to have their femur basically in a straightened position, and then angling their lower leg outward. So basically almost putting them into an abducted position to make that MCL get tight. And again, right now we're at a 90-degree angle, so we're not really assessing it so much. We'd want to be closer to 20 degrees where it's going to be really firm, and you would take it to a tightened position. The LCL, you can just put your finger on the fibula and then run a little bit superior to that, and you should be on the LCL, and then you would apply varus stress, so just going into almost an adducted position with the lower leg, and you should be able to feel the fibula get taut underneath your fingers when you go into that position. Again, the IT band is that nice fascial structure that comes off of your tensor fascia lata on the anterior 1/3 aspect of your hip. And then one thing that I kind of mentioned, but when we talk about the joint line, we're going to be able to feel it really nicely here anteriorly, but you should be able to follow it all the way around the entire lateral and medial aspect of the knee. And as you move them into flexion and extension, in flexion, it's going to start to close up, or in extension, and then as you move them into flexion, you should start feeling an opening a little bit. And again, if you can find it anteriorly, you just kind of find that space that runs in between that distal aspect of their femoral condyle and then the proximal aspect of their tibial tuberosity, which are really the two best ways to find it. And when you find the joint line, the things that you're really looking for there are going to be both of your collateral ligaments, but then also if they're complaining of pain in that joint line space on either side, you're really starting to think things like maybe meniscal or something like that. And again, it's very difficult to palpate, and so don't think that you can actually push on the meniscus and aggravate them, but certainly you can be in that general vicinity and ask if the pain is close to that area, which I think is always a really good idea. The last thing are a couple areas that we've talked about previously, which are going to be on the posterior side of the knee, and we'll talk about those in just a second.